It's a pleasure to speak, and I'm so sorry not to be there. It's just really shouldn't share the bug that I have at the moment. Yeah, so just some disclosures about funding sources and some of the work we've done. We're going to talk a little bit about why should we diagnose people early, what are the best diagnostic tests for Alzheimer's and are they being used, and what else is needed. So you may already know that the progression of Alzheimer's is really slow. So there's a very slow transition from people having a healthy brain to having a brain that's got Alzheimer's, where there's been some shrinkage of the brain. People have started to get symptoms. For much of that time during that transition, people are cognitively normal, so they would not notice any symptoms, and if we tested them, we wouldn't find any problems, depending obviously which tests we do. Then people develop mild cognitive impairment, which is when they start to notice symptoms but are carrying out day-to-day life quite normally, but they do perform abnormally on at least one of our tests. And then dementia is really the very late stage of diseases like Alzheimer's disease, where people are functionally impaired, so they can't manage to do things day to day. During this time, there's a whole host of processes happening in the brain. The one really to focus on is laying down of amyloid plaque. So A-beta-42 is a toxic form of a protein called amyloid that's laid down in clumps in the brain called plaques. And that's one of the very first things that we find in people with Alzheimer's disease. And you may also have heard of phosphorylated tau tangles, which is another hallmark pathology. But that's not all that's happening. We've got neuroinflammation, we've got wearing away of synapses, those connections between cells. I've got problems with the blood vessels that can happen very early. And also quite often there's pathology, not just with Alzheimer's, but also other types of dementia, like this bit of Parkinson's pathology, happening more often than you would expect by chance. So it's a complex process that's happening as people progress from being healthy to having dementia. And it's a very long window of opportunity where we can offer treatments. Now, this talk isn't about treatments. I could fill up another hour about the new treatments coming along, which is exciting. But I did think we needed just a few slides to talk about the sorts of treatments that might make their way into clinical practice. In fact, are available privately. They have been approved for safety, but they haven't been funded by the NHS. So there are two drugs, and I'm going to talk a little bit about this first one, donanemab, but very similar things apply to the other drug that's licensed in the UK, lecanemab. So two drugs have been approved, and some people are getting them now in the private sector. Can't give them in the NHS, though, because of the funding issue. So this is the Trailblazer ALS2 study. It was one of the two leading studies where these drugs were shown to have a clinical benefit. I think a really important thing to point out here is that when it says MMSE, that's a standard cognitive test. So MMSE 20 to 28 means people have mild cognitive impairment or a mild Alzheimer's dementia. That's where the drugs seem to work, in the mild stages. People had to have biomarker testing, so they had to have confirmation of Alzheimer's disease at a mild stage to get into this trial. And we also checked MRIs to check they didn't have too many bleeds because of some side effects of the drugs that I'll come on to. So with the treatments that we have, we know that they work a bit, and I'll show you how much they work, but they work in this very early group. Right, so what happened in the study? Well, these infusions of donanemab are every 4 weeks. So, and lecanemab is every 2 weeks. So that really means coming up to the hospital. It can sometimes, in one of our trials, we're looking at doing home infusions, but it's still quite a lot to take on having an infusion every 2 or 4 weeks in the hospital or perhaps in your home. Patients also had to have regular MRIs, and that's to look for side effects that I'm about to tell you about. And also they had fairly regular amyloid PET scans because we know these drugs are really good at clearing amyloid. So actually, if people cleared amyloid, so they'd no longer look like they had Alzheimer's on the PET scan, they could stop the drug. But it did mean extra tests. So these were quite complicated. You can see from this, there's a lot going on. It's a lot for people to take on. And then I'm going to show 3 of these graphs. So just to get your eye into what these graphs mean. If you look at this left-hand side graph, there's placebo is in grey. And this is the primary outcome. So the main finding in this trial was a test with the snappy title of IADRS. And that is an acronym that stands for a test essentially of memory and day-to-day function. So it's lots and lots of questions. The patient and the carer answer lots and lots of questions. And then this is all put into one number, and that's the score here. And you look at the grey here, you can see this it drops down, so it gets worse over time. In the placebo group, so but in the donanemab group, it also gets worse over time. So this drug is by no means a cure, but it gets worse less fast. And so this has been quite controversial. What is meaningful in terms of clinical decline is this is said to be a 35% slowing of decline by donanemab. But remember that the decline already is pretty slow in these mildly affected people. And so is 35% kind of worth it coming up for 4 weekly infusions? That's been the debate that's been going on and the reason why it's been difficult to get things funded. But nevertheless, these were momentous findings. I can't tell you how excited the auditorium was. Well, I was in the auditorium for this one, and people were standing up and cheering, which is very non-scientific, really. But you know, because we've been waiting for a treatment that worked, and this clearly does work. And they measured. This is the main outcome on the left, and one of the important second outcomes. That's another cognitive test on the right. Both show similar results, but actually there were 25 outcomes, and 24 out of 25 showed this consistent, modest benefit. So we know these drugs have an impact if given in the right people. And another way of looking at the impact they have is, again here, placebo is the grey and the drug is the green. But what you can see is that it's another way of looking at it. So how much time do you gain by having the drug? So over 18 months, you save about 4.4 to 7.5 months of decline. So you're better by that equivalent amount of time, which is another way to look at it. What we don't know is what happens if you keep taking it for longer or if you come off it and then go back on it. We just don't have that data yet. Some's coming through, but it's not clear cut yet. Okay, so these drugs work, modest benefit, but with side effects. Look, we need to do these MRIs because these are MRI scans of the brain. They're slices through the brain. And if you look at this side compared to this side, I don't know if you can see my pointer, but if you look at the red circle here, you can see that there's some swelling on this side and not on the other side. And that swelling is got a title of ARIA, which sounds quite pretty, doesn't it? But it actually stands for amyloid-related imaging abnormalities. And you can get ARIA swelling, and so an imaging abnormality that's swollen. This is the ARIA-E here in blue on the left. Or you can get hemosiderin hemorrhage, so bleeding. And actually, a bit of bleeding in the brain in Alzheimer's is actually normal. So tiny microbleeds are normal. Excuse me, sorry. But they have them at a far higher rate in the group of people who take the drug. So we've got a drug, you have to come up every 2 or 4 weeks, you get a modest benefit, we don't know what happens after 18 months, and there are side effects. This is why the situation has been critical. But if we are going to give these drugs, and I can tell you there's a next generation of these drugs coming rapidly behind them that look like they may have a much better side effect profile. And if we are going to give these drugs, we're going to need to diagnose people because they only work in people, they target amyloid, so they only work in people who definitely have amyloid pathology. But what do we do now? So what's a standard care pathway? And I actually have personal experience with this because my dad has a diagnosis of dementia, so I've been through this, and we had a brilliant GP and a brilliant memory service. And they did everything right, and GPs are doing everything right. But the way that we're set up nationally is that when GPs see people, they do a brief memory test, which most people with mild cognitive impairment will easily pass. And then we look for treatable causes, which is very sensible. Look for vitamin deficiencies, urine infections. Is someone drinking a lot? Surprisingly common that's an issue. That's another talk. And they might do a brain scan. But somebody with mild cognitive impairment would generally be reassured and probably said, well, come back in a year or two if you think things are worse. Even mild dementia doesn't always get diagnosed. In fact, we're only diagnosing 60% of people with dementia ever in their lifetimes. And usually when we diagnose people, it's too late for those newer treatments. So I showed you that those treatments worked in mild cognitive impairment and mild Alzheimer's dementia. But in fact, we're not doing that. We're diagnosing people late. So you can see the problem. If we want to get treatments that work, we've got to change services. And also it's important to point out that even if we don't have treatments, and we haven't got treatments on the NHS yet that actually modify disease, you'll know probably that we have some treatments that boost symptoms, and they do actually help some people. But we don't have treatments yet that modify disease because these ones aren't funded. But even without treatments, 3/4 of people want to know, because some people want to plan. They want to have information, they want to understand their problems, and they want to rule other things out. So they want to have a really clear answer. So there's a question of whether people actually have a right to know that they've got Alzheimer's or another dementia. Well, we can tell people. So we can diagnose earlier. We have the ability to do that already. So we've mentioned that the difference between a normal and an Alzheimer's brain, often in the first stages, is amyloid plaques and neurofibrillary tangles. And we can look for these things. So we do this routinely in our clinic in Southmead Hospital in the Brain Centre. If people want to know whether they have Alzheimer's as a cause of their memory problems, we offer them a lumbar puncture test. And when we do the lumbar puncture, we can look for amyloid, we can look for tau, we can look for some other markers that tell us if there's some breakdown of the cells. There's another test that can be done, and we sometimes do this. It's an amyloid PET scan. You only get information on amyloid, not the rest, but we don't have to do the lumbar puncture. So sometimes we do an amyloid PET if someone's got some problem with doing the lumbar puncture. I mean, quite a lot of people don't want to have a lumbar puncture, and that's perfectly reasonable. And we may then go on to do an amyloid PET scan. It's a lot more expensive to do an amyloid PET scan, but the main reason why we favour lumbar puncture is just because we get more information, particularly with some of the younger patients that we see. We can check that they don't have anything else like infection or inflammation causing the memory problems. And so lumbar puncture fluids, having a look at the fluids that tell us about the brain, because it's the same fluid that bathes the brain and the spinal cord, really gives us a window onto what's happening in the brain. So if I was in the room, I was going to ask a question now. I don't think I can do that because I can't hear the answer. But anyway, just something to think about is how many people do you think who come to their doctor with memory problems are being offered biomarker testing to tell them whether or not they've got Alzheimer's, which at the moment is lumbar puncture or amyloid PET? What proportion? I'll go straight on to answer. Well, we know that about 2% of people are offered some form of biomarker testing, and about half of those, it's actually biomarker testing for Parkinson's disease. It's a different sort of scan called a DAT scan, which is really good. It's a good scan, but it's not Alzheimer's. So we know 1% of people who make it to a memory service are being offered biomarker testing. And without that biomarker testing, we know we're wrong 30 to 40% of time about the cause of dementia. So if we're going to offer treatments that target the molecular basis of Alzheimer's disease, we have to do biomarker-driven diagnosis. It's the first step. Now, it's very difficult because lumbar puncture and PET scans cost some money, but we have blood biomarkers. So you might have heard of some of this. There's been a lot of talk about this. And the reason why we've only just got blood biomarkers now is because technically it's hugely challenging. So the brain is a privileged site. It's protected by something called a blood-brain barrier. And the blood-brain barrier doesn't let out a lot of the proteins that are in there, but we want to know what's happening with those proteins. So to find those proteins, because just a small amount leaks out, it's like looking for a couple of grains of sand in an Olympic swimming pool. That's the sort of sensitivity of technology that we need. So that technology is now available. And so we can start to look for markers of amyloid, markers of tau, markers of neuroinflammation, which we know, interestingly, looks as though it's abnormal as well as these proteins. The way that our body responds, our immune systems fire slightly abnormally in some cases, at least some cases of Alzheimer's. We can look at all sorts of markers now in the blood. But it takes a long time to get an accurate test. You know, we're doing something that's right at the limits of what we can detect in terms of the technology that we have. But one of these tests, so if you look at this graph here, phospho-tau 217, and you compare phospho-tau 2, so this graph is comparing phospho-tau 217 to the gold standard diagnosis for Alzheimer's. And what we find, if you see here, it's 96% accurate. So it really is looking like a good clinical test for Alzheimer's. And I said a couple of years ago, thought we'd have the blood test in a couple of years. I'm still saying I think we'll have the blood test in a couple of years, because actually the first one has come through. So UCL will now offer a clinical blood test for plasma phospho-tau 217. So we're looking at how we deliver that. But we have to be really careful, because unlike in the brain, which is this privileged site we've talked about, the blood, if you've got kidney problems or if you're on certain drugs, the blood's affected by all of those things. If you've recently had a heart attack, even something like obesity can affect the levels of these molecules in the blood. So while we might start to deliver the phospho-tau 217 in blood as a clinical test, we would do it very, very carefully. And we are waiting for the outcome. There are two very large, so they're both in the region of £5 million worth of funding, clinical trials. One's called ADAPT and one's called READOUT. And READOUT is the one that we're involved with, where we are looking at the sensitivity, the real world sensitivity of phospho-tau 217 as a blood test for Alzheimer's. And we're also looking at all the other tests, just to make sure that they really are accurate. But they look very, very promising. So we have the blood biomarkers, and we have these beautiful models. So we know that blood biomarkers should become with A beta, which interestingly, the phospho-tau 217, even though it's called tau, is a very good marker of A beta. So we know that A beta should look at this curve. It should become abnormal, but 10, 15, even 20 years before someone has Alzheimer's dementia. Then the tau starts to become abnormal, then brain structure starts to change, and then we get this beautiful curve of memory change, and we can understand exactly using these models what happens. But then what happens in real life, because we've had these tests. So this paper was very, I thought, illuminating. It looked back at people who definitely had A beta, so they had memory problems. They had evidence, biomarker evidence of Alzheimer's disease. We knew they had early Alzheimer's disease. And so do they follow that beautiful curve? So across 934 people, this is what happens. So as with most tests in medicine, if you look on average, there's a beautiful curve, and the test baseline abnormal tells us that people will gradually progress. But in fact, some people progress much faster, and others progress much more slowly. And so on here, the way this graph is done, 0 means no change across the CDR change from baseline. -2 means things got better, and +2 means things got worse. So most people got a bit worse, as we'd expect over time, because we know they've got A beta and they've got memory problems, therefore technically got the diagnosis of mild cognitive impairment due to Alzheimer's. But there's a great disparity, which is why we have to be careful. So what are we going to do next? We have to do a little bit more, don't we? So how can we make accurate predictions for an individual? So if I go to the doctor, if you go to the doctor, I want to know what's going to happen to me. I'm interested in what happens on average, but that's not necessary. I'm going to talk a bit about MRI scans. We have them available, we can use them. I just talk a little bit about how we might be able to use them a bit better. I'm going to talk about functional markers, which means basically memory tests. And I'm not going to talk that much about sleep, because it's a major interest in my group. So I'm aware that I can bang on about it quite a lot. But just to say that some of my colleagues, so Victoria Gabb, Jonathan Blackman, Mason Taylor, have been doing some fantastic work on sleep. And we're starting to see some patterns emerging, that sleep becomes abnormal in some sorts of dementia. We can talk more about that later if of interest. But we're still really understanding that. So I'm going to talk about these bit more established tests. So MRI scanning. You may have had an MRI. So it's a giant magnet shaped like a tube. You go inside, you have to stay really still, but it's very noisy. So you often get given headphones, and we can using our MRI now we can get really good pictures. And where are we interested in? Well, Alzheimer's presents differently in different people, and there's no doubt that you can present with visual problems, with spatial problems, with language problems, with behaviour problems. But the commonest presentation of Alzheimer's is memory problems. And that typical pattern is when people can't remember things over a few minutes or a day or a few days. They might remember their childhood very well because those are firm memories that have been stored over years. And they might remember things that happened a second ago very well, like they might be able to whisper a phone number and recall that as they walk across the room. But it's things that are laid down. So if you're still remembering anything from my first slide now, then that would have gone into an area of your brain called the hippocampus. And the hippocampus is a memory area. And the actual structure of the cells in the hippocampus, the synapses, the way they join together, will have changed a little bit to allow you to remember. Can you remember the colour of my first slide? That sort of thing. That would have required some, unless you've been thinking about the colour of my first slide all the way along and holding it in mind. But if you haven't had it in mind and now you can recall it, it's because it's changed the structure of your hippocampus. And that's the area that we know is reduced. It's marked in here on this scan. It's tucked right inside the brain. So you don't see it on the outside, but it's tucked inside. And we can, classically in medical practice, we can look at it and people give it a rating scale of normal or slightly small or very small. And there's various ways to do that with some accuracy. But over recent years, we've got some automated hippocampal measurements. So we can put those in and we can do a more objective measure of the size of the hippocampus. And also we know the whole hippocampus doesn't change at the same rate. So you see these different colours on here, which are obviously overlaid. They're different areas of the hippocampus, and some areas change much earlier than others. So we can actually, rather than looking at the whole structure, which already is a very small structure and hard to see, but we can actually look at just one area and say, is that area smaller than it should be? That's typical of Alzheimer's disease. And areas just outside the hippocampus, like the entorhinal cortex as well, change very early in Alzheimer's. So by looking in more detail at MRIs, we can get a clearer picture. And the other thing that we did in our group was, rather than looking just at the size, we tried to use the MRI to look at the consistency. And we did that by looking sort of pixel by pixel across this MRI, looking at the variability within different regions of the hippocampus. So not just the size, but the variability of these different pixels. And this is just one graph to show that actually, and we've obviously published this, the variability, that pixel by pixel variability in the hippocampus helps us, it tells us whether someone will decline over time. So we can get a bit more information. You know that even with amyloid testing, some people didn't decline. This gives us a little bit more information. We can get that out of an MRI scan. So MRI is really great, and a very exciting thing that's not been done by us, but done by UCL, particularly Nick Fox, Professor Nick Fox, who's a real leader in dementia MRI, is ultra-fast MRI. So one problem is we have it available in North Bristol. We've got 4 MRI scanners in the hospital and others that we have access to around. We really can use it, but it takes 20 minutes, half an hour to get a plain MRI of the head, which is a lot. And if you can get a CT scan, you can get one in about 2 minutes. So, but they're using ultra-fast MRI and actually getting the same resolution across only a few minutes. And if we can start to bring that in, then it makes it more realistic that we can use MRI. It won't be as expensive because we can get more patients seen in the same time. So all of those advances mean that we can start to use that tool more, because at the moment most people don't have an MRI. Most people have a CT scan. Excuse me. Right, and then I talk a little bit about cognitive tests. Sorry, excuse me a second. About cognitive tests. So a few acronyms on here, apologise for that, but if I wrote it all out, it looked worse. So we have lots of cognitive tests. The one we use in clinic is the Montreal Cognitive Assessment, often called the MOCA. And there's another common one called the Addenbrooke's Cognitive Assessment. There's a mini-mental state examination, and then the ADAS-COG, another more detailed memory test, something called the PAC-5, and the R-bands, the repeatable battery of neuropsychological tests. And this PAC-5 looks like it's very sensitive to early change. So these batteries are being developed all the time, and there's a few of them. And if you do a trial in Alzheimer's and you want the drug to be taken, the FDA, so the American Regulatory Authority, and the MHRA will only accept some of these tests. So you pretty much have to do them. You have to do one of these acceptable tests if you to qualify to say this drug really worked. But there are limitations, and so there's some very exciting work to do precision cognitive tests, because these tests, the other ones I just showed you, tend to be things that you might have experienced, like remembering a word list, naming 3 animals, drawing a clock, that sort of thing. But they might not tap in directly to the areas that we're interested in for Alzheimer's disease. So Dennis Chan at UCL has done some amazing work with tests that are a bit like this. So here they're using virtual reality and getting people to navigate between 3 points, and they had to get back to the start. They couldn't see where they'd been. They had to just remember where they had to use their inner navigation system. They're actually just in a clinic room, but they feel like they're navigating a terrain. And we know that an area of the brain I mentioned before that's just outside the hippocampus that you could see on the last scan, entorhinal cortex, is really important for this sort of navigation. And that's a beautiful demonstration of understanding in mice what the entorhinal cortex is, and then translating it into humans and finding this quite reliable early cognitive test. The difficulty is then translating that into clinical practice, because we could do virtuality, but it's a bit of a way away from what we currently do. And people already find doing a memory test quite stressful. And I think virtual reality in a first appointment would, we may end up doing it. I mean, things are changing very fast, but we're not doing it at the moment. We've developed our own precision memory tests. So what we have been thinking about is that when one really good way to store memories is to sleep on it. We say it all the time, don't we? Before a big exam, have a good night's sleep, you get your memory. Sleep is really important for memory, and we can talk about that at length. But all the memory tests that standardly we do for Alzheimer's are over about 20 minutes. But we know that sleep's affected early and memory's affected early. And so we had a look to see if sleep-dependent memory, so the things where you see them on one day and then you go away and you remember them a week later because you've sort of slept on it. You haven't been thinking about it. Your brain's been automatically organising things often during sleep and storing things away and also forgetting things. So forgetting's quite healthy. Forgetting's quite important. But we found that people who forgot things faster at baseline, even healthy older adults with no symptoms, were more likely to decline in their general cognitive function over a year. It's been shown that this tendency to forget links to Alzheimer's disease pathology. The problem is that if you're stressed or if you're not really interested in doing the test, so there are so many things that can confound these memory tests. So sometimes we've done them lots of times, so someone says, well, I remember that from last time. Even though we do our best to change the version, if someone's very highly educated, they might have a better memory to start with, and so their memory might actually be quite impaired, but we can't pick it up. And then people are stressed or demotivated, or we might not be doing the right test. We might be showing people things that just aren't culturally relevant to them, so they don't remember it. So that is why, although we're working very hard on these precision cognitive tests as early diagnostic and supportive measures, and they may be good, we're really excited about fastball. So I have to give all the credit here to George Stothart, who's my colleague in Bath. He developed this technology and we've worked on the implementation together, but he really has done an amazing job on this. Fastball is a test where someone can just sit still, look at a screen, and they don't have to do anything. They don't have to be stressed, they just have to look straight in front of them. And it takes advantage of the fact that we can pick out brain rhythms if they're very regular. So what happens is people are shown some items to remember, and here they're on the left. So the cork and the calculator. And then we show them a whole rapidly presented stream of items, but every fifth item, and the frequency can be slightly adjusted, but here for this example, every fifth item is one that they've just seen. So you and I, hopefully we've got good memories. We can our brains will just ping when we see that calculator, and because it's a regular rhythm, that signal is really strong. Because there'll be lots of other items that have been remembered too. It just takes 2 or 3 minutes. Just wear a cap, which is an EEG cap. And what we showed was that people with Alzheimer's didn't remember those items. So it's an automated, effort-free memory test. And it gets rid of a lot of those problems that we have. And they really are problems where people quite often are just so stressed when they come out to see us in clinic that they don't perform as well as they could. And then it's really hard for us to understand what is the problem. Here's George running the test, and we've got a big grant now from the National Institute of Health Research to deliver this in clinic. So we're offering it to everybody who comes up to clinic, and we're comparing it to standard memory tests. We're often using biomarker diagnoses anyway in clinic, but we're also doing some blood biomarkers on people, and then we'll also have a clinical diagnosis that we make based on everything. And we're going to compare the results of fastball to all these other things to say, is it useful in future to do this memory test? Could you come up, put a cap on, look at a screen, and then you wouldn't have to do all the memory tests that we do. And there's other versions of fastball that look really exciting that are being rolled out. So we haven't got the results yet. It's another year or 2 of testing, and then we'll know. But I think we are throwing everything at it, and we've got a good number. I think we've got 500 people recruited so far. So we will know, and we will know either way. Right. But how do we combine all this information? So I'm a medic. I don't know much about artificial intelligence. I'm not a computer scientist. I've heard of it. It's in the news a lot. Artificial intelligence to me is a way of combining information that would otherwise be hard to combine because of the scale or the complexity. There's probably a better definition, but that's how I see it. And when we've got all these different MRIs, cognitive tests, different things about people, demographics, age, education, it's just a question of, can we combine this information a bit better? Well, fortunately, we're working a bit with someone called Professor Zoe Coetzee, who's brilliant. She's based in Cambridge. And what she did was she looked at a big data set that's established with lots of data in MRI scans, cognitive data. And she thought, well, we know that these people who have Alzheimer's don't all progress at the same rate. So can I take some simple data, add it to the fact we know they've got Alzheimer's, and tell who's going to progress and who isn't? And she did. So she used MRI and a couple of cognitive tests, and she separated people into. So if you look at the black bar on here, the black line on here, that's the average. That's people with mild cognitive impairment, and that's what happened to them on average. And then she used her algorithm, which is an AI algorithm, to pick out people who had mild MCI and stayed stable in green, people who were very rapidly progressive in red, they changed quite quickly, and then people who were somewhere in between, slowly progressive but not stable. Well, that's interesting, but it's just on one data set, so you don't know if it applies to another data set. But she managed to get hold of some data from a failed trial. So this trial was sort of a drug that influenced the Alzheimer's pathway through another mechanism called BACE inhibitor. Doesn't matter, really, but it was a failed trial. And she got hold of the data and she asked the question, well, maybe the drug would work in someone who is a rapid progressor or a slow progressor, but not both, because those people are quite different stages of illness or types of illness. So let's have a look. And what she showed was that actually, if she just looked at the people who she defined as slowly progressive based on her other data set, using very simple data in her AI algorithm, the trial was actually positive. So bear in mind the significance of this, because these trials are millions and millions and millions of pounds, and if they are negative, there's a loss of a treatment. We give up on something that might have been promising, and the drug company and life sciences sector itself loses money, vast sums of money. So what she showed, and if you hear just to get your eye in, look at the slowly progressive group here on the left. This is CDR sum of boxes, which is one of the tests we've seen a few times. It's a cognitive test called the Clinical Dementia Rating Scale, and it weighs worse when it's up. So going down is good, even in terms of the change. And the placebo group, the slowly progressive, showed a certain change, but the 20 and the 50 milligrams, the trial was positive in the 50 milligram group. So the way that she looked at this was to say, well, with a trial, even with lots of people in it, if you accidentally have lots of rapid progressors in one arm and lots of slow progressors in another, because you haven't looked to see who they are, because you didn't know until this point, you're going to get an unbalanced result. So that's really effective, the way that we're going to do our research. So we've just got a large grant. It focuses on our intervention, our sleep. So we're interested in sleep. We want to be able to improve sleep. And we are going to give people interventions that improve, we think, the slow oscillations during sleep. So this will be run across the UK at 11 sites. And we will give people, it's all placebo-controlled and sham-controlled, but we'll give them a drug called trazodone that improves, they'll be blinded so nobody knows who's getting what, but that improves slow oscillations. A drug called zolpidem that improves sleep but not slow oscillations. And a drug and a device that improves slow oscillations called Sleep Loop. So the trial's called Sleep Boost and the device is called Sleep Loop. And everyone will be randomised to one of these arms, so everybody will have a device and a drug, and they'll take it for a year. And we're going to use blood tests to tell us whether or not Alzheimer's pathology is reduced in this group. But what we're going to do is use Professor Coutthard's algorithm to balance the groups. So we're going to get some information about people at the start, the level of their biomarker, their cognitive performance, put it into the algorithm and balance the group. So we've not got lots of rapid progressors in one group and lots of slow progressors in another. And then we're going to use in-home devices. So the stimulation device, Sleep Loop, slow oscillation stimulation, but also sleep recording devices, wrist-worn devices, actigraphy to measure activity, to get a really clear idea, as well as memory tests and also MRI scans, get a really clear idea of how improving sleep affects Alzheimer's disease, memory and the brain. And hopefully we're using absolutely state-of-the-art technology to diagnose and categorise people. Okay, that was a lot of information. I hope it's been clear, but I actually, part of this is being ill, because I was actually pretty much bedbound for the last 2 days, and I did think, why is it so important to me to come to the Brace conference? They probably hope I'm not coming because I'm got a bit germy. But I did think, why is it so important? And then I thought, well, Brace has just been so important, so I thought I'd outline some of the things. This doesn't include everything, but some of the things. So I first heard of Brace when they actually made a consultancy. They funded a consultancy in the electoral post alongside North Bristol NHS Trust in 2011 that I applied for and got. And there was the Brain Bank, which was fantastic, and Brains for Dementia Research, which was fantastic and really useful to talk to Pat and Seth and Laura and Candida and that great team, which but there was not much clinic. There was no clinic in the North Bristol Trust for Dementia, and there was no research in clinical research. But one other thing Brace did that was amazing is that they funded first the Brace Centre on the French side, and then the Brain Centre, which was mixed with MS and movement disorders, on the Southmead side. So we had a place to do our work and the support of Brace. I can't tell you how important that is. And do you know, when I was looking back, these are just some of the PhD students, so PhD and MD students, who have done some brilliant work and are now, many of them, academics or clinicians, and all wouldn't have been able to do their work if it wasn't for brace funding. Some of them are actually brace funded PhD students. Some of them aren't. Some of them are funded by Wellcome or MRC or other people. But still, they were using the Brain Centre and the Brace facilities, and some of them got extra grants from Brace. Our nurses, so I need to get a better photo of our new nurse. I've got one just coming up next. But this is, at the top is Deanna, who's one of our two lead nurses, getting a North Bristol Trust Hero Award. She's just second off on the right there. And then two of our other nurses here who've been really fantastic, and Brace has continued to fund a nurse for us, which just makes such a difference to the research that we can deliver, because we want to be able to offer research to everybody who comes through the door. And then we've now got 5, including me, I'm not one there, but consultant neurologists, so that's people down this right side. So most people are funded by the NHS. And why have the NHS funded more consultant neurologists? Well, because we're a going enterprise. We've had a lot going on. We've got our own building. We've got support. And then most recently, Jonathan at the bottom here has been funded as a consultant senior lecturer, same post as I had 14 years ago. So that is so exciting, because now we've got another foot in the university to generate more PhD students and more research. We've got some amazing research associates. This is just the current ones. I missed people off. I couldn't fit everybody on. But again, their careers have been really changed by the ability to deliver the work. And also just count Julie Clayton, our patient and public involvement coordinator, but also all the people. This is just a photo of a small number of people who are stakeholders from the NHS, patients, the public, carers, who have helped to deliver some of our work. And also some of the networks that we're now recognised and able to join, so the UK Dementia Trials Network and the Dementia Translational Research Collaboration. And it's not all about money. We've had the support, sometimes we've had a bit of support from Brace with defending our territory, and just strategic support has been really good. And now we are delivering, our portfolio of trials that we're setting up delivering is over £12 million, which is not the be all and end all. Sometimes you get the most brilliant result from sort of £15,000 grant, and that's amazing. But actually that, we really are doing a lot of work in that brain centre. So here's a photo. Here's some of the other funders that we brought on. Well, they've agreed to fund us. I shouldn't say we brought on. They've agreed to fund us, and that's been brilliant. And here is us from the Brace event a year or so ago, all in our best clothes. And the two at the edge, Gianna and Kath, are our lead nurses. I'm going to stop there. Thank you very much.